Hello. Thank you to the organisers for giving me the opportunity to present this case. My name is Tomas Burke. I'm a consultant ophthalmologist in medical retina, uveitis and cataracts, working at the Bristol Eye Hospital in the UK. This is a case on the use of Iluvien for bilateral chronic anterior uveitis with macular edema. These are my disclosures. So this is a complicated history, but let's pick up the story in 2012. It's the case of a 65-year-old Caucasian woman who has a history of bilateral chronic anterior uveitis with cystoid macular edema, diagnosed for at least 2 years. She had been extensively investigated, but no underlying cause had been identified for her uveitis other than B27 positivity, but without spondyloarthropathy. This lady was bilaterally pseudophakic. She had a right posterior capsular opacification and right amblyopia. She had been intolerant of multiple second-line immunosuppressive agents, including biologic agents, and we had to have cautious use of systemic steroids because she was known to have osteoporosis. She had had multiple intravitreal triamcinolones previously, but without intraocular pressure rise. In 2012, we can see that the right eye was more active than the left eye in terms of anterior chamber inflammation, and she had a right posterior capsular opacification, limiting her vision. The decision was made to give an intravitreal dexamethasone implant to help control her anterior chamber inflammation, with the plan to proceed with a right YAG posterior capsulotomy. She was treated with various doses of prednisolone 1% eye drops to both eyes. 2 months after her right eye Ozurdex implant, we can see the right eye is quiet, but the left eye was inflamed in the anterior chamber with 3+ cells and cystoid macular edema. So at that time, the decision was made to give an Ozurdex implant to the left eye, given the very good response in her right eye. Over the following 2 years, she went on to have 7 intravitreal Ozurdex implants to both eyes, and we can see the yo-yoing really of her visual acuity, reducing with each uveitis flare. And then when the Ozurdex implant was given, her uveitis became quiescent and her visual acuity improved. Again, you can see there was no intraocular pressure elevation. Given the multiple intravitreal Ozurdex implants that were required to achieve quiescence of her uveitis, the decision was taken to apply to the health authorities in the UK for Iluvien intravitreal fluocinolone implants. This application was made in January 2014. By the time the use of the implants was improved, and I should say that at this time, this was an off-license use of the intravitreal implant for the control of uveitis. We can see that the left eye was severely active in terms of the anterior chamber inflammation with the hypopion, while the right eye was minimally active. So she had approval for bilateral sequential intravitreal Iluvien implants. The left eye was first treated with the plan to then treat the right eye. Interestingly, the hypopion in her left eye actually resolved within 1 week of the Iluvien implant. 3 months after the bilateral Iluviens, both eyes were quiet with no increase in intraocular pressures and with no cystoid macular edema. The plan was to taper her prednisolone 1% eye drops. Comparing and contrasting the visual acuity behavior during the treatment periods with Ozurdex versus Iluvien, we can clearly see the stability that was achieved with the intravitreal Iluvien implants in both eyes. And she had no significant intraocular pressure elevation from during those first 2 years of treatment with the Iluvien implants. Approximately 3 years after the bilateral Iluvien implants were given, her left eye flared significantly with again a hypopion anterior uveitis, a limited fundus view and hand motions vision. The plan was then to give a further Iluvien implant to the left eye. 2 weeks after that second Iluvien implant, we can see that the left eye vision did not improve. There was a minimum hypopion. So the question was, why was her left eye still inflamed? An ultrasound B scan carried out when she attended clinic revealed no implant visible in the vitreous cavity. And so as a temporizing measure, an orbital floor triamcinolone injection was given while we figured out the next step in her management. 1 week following the orbital floor triamcinolone, the hypopyon had resolved and her visual acuity had started to improve. So this suggested that there was not a functioning steroid implant within the eye, as her uveitis appeared to be steroid responsive. Therefore, the decision was taken to implant further Iluvien implant to the left eye. We proceeded with this injection. At the time of injection, she had 3+ anterior chamber cells in her left eye. 2 weeks following this third intravitreal Iluvien implant in the left eye, or the second functioning implant, we can see that the visual acuity has picked up. There is no macular edema, and the eye is quiet on examination. She then went on to have the planned Iluvien implant in the right eye with a view to preventing further relapse of her uveitis. 2 years after this second cycle of functioning Iluvien implants, we can see that both eyes were quiet and she was not on any topical therapy. Again, her intraocular pressures were normal and she had no macular edema. This graph then again shows the behavior of the visual acuity from the Ozurdex time period through those first Iluvien implants, and then in the time period where we had the flare of the uveitis, particularly in the left eye, and then the second cycle of functioning Iluvien implants again achieved stability and quiescence of her uveitis. The central retinal thickness behavior is presented here at the bottom of the slide, and I should point out that when this lady had flares of her uveitis, there was an absence of fundal view, so it was impossible to get a central retinal thickness during the time period of her most severe flares. Here again, we also see that the intraocular pressure did not significantly rise over the time period of treatment with her Iluvien implants. Her last planned face-to-face visit was actually in November 2019, but she did not attend. But a telephone clinic call at that time revealed that she was asymptomatic and had actually attended with her optometrist and been told that her intraocular pressures were normal. Then, due to the COVID pandemic, she was unable to attend the eye hospital for further reviews. So the take-home points really are that Iluvien can be considered as a treatment in chronic anterior uveitis with a view to preventing relapses. It can actually have a rapid onset of action for even severe inflammation. But really importantly is that care must be taken with the insertion of the implants. Positioning of the injector is important, and there is the possibility that if the injector is held with the needle pointing down to the floor, that the implant may fall from the injector. And it is also important to check the implant prior to injection, that the implant is clearly visible within the injector. I would advocate that anybody taking up the Iluvien implant for injection watches the video that is available from the manufacturers, which is very helpful and informative. This case has been submitted to the AJO case reports, and I'm hoping it will be accepted and available for download and reading. Please email me on my email below if you have any questions, and thank you very much for taking the time to review this case.